Are you guys ready for a quick revision? This is medical revisions where I will be using flowcharts, some pictures, and of course the repetition and just saying one thing again and again so that it will just get into your head. It's perfect for exam revision. So in this video, I'm going to talk about abdominal aortic aneurysm, which is one of the high yield vascular diseases. So let's dive right into it. Let's talk about the pathophysiology first. I'm going to show you guys a picture. Um, First of all, so these are the layers of our aorta. Basically, this is the lumen, this is the intima, media, adventitia. So what happens in abdominal aortic aneurysm, AAA, I'm just going to say that, it's just a mouthful. There is destruction of all the layers of our aorta. So not a single layer is, spared. There is essentially due to the stress or the connective tissue diseases or degenerative diseases, for whatever reasons, there is damage. So there is elastic degradation. We know that there is elastin and collagen in our arteries. So there will be elastin degradation, which will lead to accumulation of lots of like lymphocytes and other inflammatory markers like cytokines, etc., which eventually will lead to the death of poor small smooth muscle cells. Okay, and over the time, because of the death of smooth muscle cells and inflammatory markers and lymphocytes, and there will be very important thing, there will be proteolytic enzymes. So these proteolytic enzymes will also add on to the destruction of the whole aorta. Eventually, because of the all the wear and tear, this can lead to thrombosis, and also the rupture, of course. This is just like a AI generated picture. Don't look at the label. This is what are the steps. These are the steps. So there will be extracellular matrix degeneration because of the proteolytic enzymes, and then there will be chronic inflammation. There will be lymphocytes, um, and there will be death of smooth muscle cells, and of course there will be damage and rupture, dilatation, etc. So moving on, now that we have that in mind, let's look at the pathophysiology points. It is a failure of elastic proteins, okay? Elastic proteins, collagen, extracellular matrix, it's destroyed in AAA. There is dilatation of all the layers of arterial wall. It's not just the media, it's not just the intima, it's all the layers of arterial wall that are dilated. It is mostly located in the infrarenal segment of aorta. Most of the times, 80 to 90% of the times, it is located in the infrarenal area. So look at this diagram or picture. These are the kidneys, renal, and below that, so it's infrarenal. That's how you remember. 80 to 90% of the time. Most of the times, it is caused by degenerative diseases. Okay? We say that it is an aneurysm when it is equal to or more than 3 centimeters. Most of the times in females, it is 1.5 centimeters, and in males, it's 1.7 centimeters of diameter. But if it is more than 3 centimeters or equal to 3 centimeters, then we define it as aneurysm. So as I mentioned before, the primary event of the pathophysiology is the loss of intima and elastic fibers from the media. So the whole layer is being damaged. And also there is increased proteolytic activity. So these proteolytic enzymes are just going to come and they're going to eat up the whole arterial wall. And again, as I mentioned before, there are going to be lymphocytes and other chronic inflammatory markers. So these two are very high yield points. There are going to be proteolytic activity, proteolytic enzymes, especially called MMP, and then there are going to be lymphocytes. So this is the pathophysiology. Let's look at the risk factors. Smoking and hypertension. You will see this in all the questions when AAA is asked. So smoking is essential. Smoking, hypertension. It's said that if even if someone has a one cigarette in their life, it can cause, or it can actually lead to AAA. So smoking is a big risk factor. Hypertension, and then there are some rare causes. They are not very common, but infection like syphilis is one of the rare causes of AAA. So it can be asked in the question. Syphilis is very a rare cause. Still, you know, if you want to learn, you have to learn this infection. Remember this. And we all know that there are some connective tissue diseases like Ehlers-Danlos syndrome and Marfan syndrome. So Ehlers-Danlos type 1 is associated with the AAA and Marfan, of course. So the most important risk factors are smoking and hypertension. Remember this. Let's move on to the screening, because our management depends on the screening. So because most of the patients, they are asymptomatic, and we have to check, we have to screen them because it can be a matter of life or death. So it's important to, screen the patients. A single abdominal ultrasound, especially in males who are above the age of 65 or 65, we have to get their single abdominal ultrasound at least. What are the outcomes and actions? So if I'm just going to close this so we can go through one by one. Okay, so if the aorta diameter is less than 3 centimeters, it's considered normal. It's not even an aneurysm by definition, because it should be more than or equal to 3 centimeters. So no further action is needed. If it is 3 to 4.4 centimeters, then we say it's small. It's a small aneurysm. So for that, we have to rescan every 12 months. We have to see if it is increasing in size or how's the flow, etc. So if it's a small aneurysm, 3 to 4.4 centimeter, we have to rescan it every 12 months. So I'm just going to open it so you can review it whenever you want. And if it is 4.5 to 5.4 centimeters, a medium aneurysm. Okay, 3 to 4.4 was small, 4.5 to 5.4 is medium, and in this case we have to rescan every 3 months. Here we needed to rescan every 12 months. Because it's medium, now we have to rescan it every 3 months. Now the big guy, if there is 5.5 centimeter or more, it is considered a large aneurysm, and we have to take some kind of action, So we have to refer the patient within 2 weeks for any probable intervention. Now, what will be the intervention? First, let's just review the screening actions. So 3 to 4.4 centimeter is small, it's considered a small aneurysm. 4.5 to 5.6 5.4 centimeter is called sorry, I'm too sleepy. Is medium AAA, and 5.5 is a large AAA. So for a small one, we have to rescan every 12 months. Remember, for a small AAA, which is 3 to 4.4 centimeter, we have to rescan every 12 months. For a medium one, we have to rescan every 3 months. And for a large one, we have to immediately refer. We cannot wait. We have to refer within 2 weeks. Okay? So let's look at the management. If it is a low rupture risk, it means that it's not large, it's either small or medium. So, and also, this is important, the patient is asymptomatic. The patient is asymptomatic, so we consider it a low rupture risk, okay? It's less than 5.5, patient is asymptomatic. What do? We will just use the abdominal ultrasound surveillance as mentioned previously. Like we have to either rescan every 12 months if it's small, or rescan every 3 months if it is medium. And we optimize the cardiovascular risk factors. For example, we beg them to please stop smoking, because it's going to be something that you don't want. So yeah, we have to optimize the cardiovascular risk factors. Ask them to stop smoking nicely. Okay, so the next thing is, if it is a high rupture risk, so it can either be like more than 5.5 centimeter, or the patient is symptomatic, or it is rapidly enlarging, like more than 1 centimeter per year, then what we have to do, we have to do the same thing. We have to refer within 2 weeks for probable intervention. Okay, we have to refer the patient for 2 weeks for probable intervention if it is a high rupture risk, AAA. What are the treatment options now? I'm glad you asked. So first is EVAR. EVAR is a cute name. EVAR. It's elective endovascular repair. EVAR. Okay. So in this one, we just do a simple thing. We use the femoral artery. We place a stent, and that looks a bit like this. This is the stent. Basically, the idea is to control the blood flow, so that there won't be any other damages. But there is a complication like endo leak, and most of the patients, they don't even know that they have this kind of leak, unless they just are diagnosed on a regular follow-up. So we don't have to study for the leaks, but I'm just going to include these images so that you remember that one of the complications of the EVAR is endoleak. There are many types, so the cardiologist or the interventional cardiologist, they have to, memorize it, but we don't, luckily. Okay, but if the EVAR, elective endovascular repair, is not suitable, then they have to be repaired with a surgery. So we have to go for an open repair. Okay, so the treatment options are pretty simple. So this was the AAA abdominal aortic aneurysm. If you want to learn more about other diseases, which I'm going to make a video on, please like this video, share, and keep on watching. Bye.